Hello, everybody. This is Dr. Angela Lin, the co-director of the MGH Myhre Syndrome Clinic, and this talk will be about Myhre syndrome and neoplasia, mostly tumors, types, frequency, and surveillance. I want to disclose that I also work for the foundation leading the Professional Advisory Board. I am on the editorial board for the American Journal of Medical Genetics, and I also serve as a geneticist consultant to the Massachusetts Department of Public Health. I do not have formal training in oncology, and so I welcome the comments, the criticism, whatever from my colleagues who are that. So in 30 minutes, I'm going to try to review the association of SMAD4 mutations and neoplasia. I'm going to distinguish between somatic, loss of function variants, which are very well-known causes of cancer, and germline gain of function variants in Myhre syndrome, which is new and rare. And I think this has caused a lot of confusion for people just learning about this. I'll present some cases. The 6 cases that we described in 2019, some new patients who have proliferative bone lesions, but it's not cancer, and 2 new individuals with hypothalamic hamartoma. We'll discuss whether cancer surveillance is necessary for women with the SMAD4 arginine 496 cysteine variant, and we'll talk about whether there should be surveillance of the brain, whether there should be brain MRI. And I realize this may be frightening to people, so I'll try to present it in a way that is, as objective as I can. I encourage anybody listening to report cases, even just 1 or 2, because this is how we will build our knowledge base. So I'm going to show just one big developmental slide, but it's really important. So SMAD4 belongs to the TGF-beta signaling pathway. And when I talk to my patients, I try to help them understand we don't want to think about one gene in isolation. Think about a cascade, think about interacting pathways. And this is very well known. So for some, this helps us out. I'm citing Le Goff et al. So this is the group from France. They were one of the 2 groups in 2012 who reported the gene. So this is SMAD4. It's easy to say. It's on chromosome 18, the long arm Q at position 11.2. SMAD4 is unique. It's called a cooperator. It reminds me of a child at the playground. This is a gene that works with other genes. We call it the co-SMAD. Loss of function means less activity. Gain of function means activating. And sometimes when I talk about Myhre syndrome, I find myself using my hands. As we talk about some of the pathology, I know the parents will understand what we're talking about. I'm not going to go through this, this lovely diagram in more detail. Both of the variants, isoleucine, position 500, arginine at position 496, are involved in what's called transcriptional activation of SMAD4. So I realize I'm talking to both my colleagues who are geneticists and researchers, more expert than I am, as well as parents who are listening. SMAD4 remains the sole known genetic basis of Myhre syndrome. So patients out there who might be said to have Myhre-like syndrome, I wouldn't call them Myhre syndrome. I would say they need to be intensely studied to find a variant gene. And in the literature, there's really only one patient that presents this sort of dilemma. So to move on, we're going to talk about SMAD4 in its role from cancer to syndromes. So if you mention SMAD4 to an oncologist or geneticist, they'll shake their heads and say, of course, yes, we know it's associated with cancer. It's a tumor suppressor. It can cause polyps in the colon. It's very familiar as causing a condition called juvenile polyposis. And we actually think of these polyps as hamartomas. There's increased colon and gastric cancer risk. But it's also moving into the realm of vascular disease. So SMAD4 variants are also involved with aneurysms, aortic dilation in HHT, talk about that later, and aorta, mostly hypoplasia, Myhre syndrome. So the phenotype for SMAD4 is expanding constantly from mostly GI cancer to these multi-system disorders requiring a specialty team. So it's not just a matter of quick genetic counseling, you've got to manage all these different issues. This is an important table, and I hope it will make sense. At the top, I'm listing a very familiar disorder to physicians and geneticists called hereditary hemorrhagic telangiectasia, HHT. It's known for causing these tiny little AVMs in the nose, which cause nose bleeding, in the lung, in the brain, in the gut. And on the skin, they're called telangiectasias. This is a mutation in the germline in either a sperm or an egg. It's a loss of function. Of all the patients who have HHT, only 5% have this type. There's also a very familiar disorder called juvenile polyposis syndrome. And juvenile doesn't really mean children, it refers to the type of the polyp. Again, it's germline, it's loss of function, it's caused by SMAD4, but also another gene, BMPR1A, which is equally as common. But here's SMAD4 in the role as causing cancers: pancreatic, colorectal, breast, stomach, lung, liver, adenomatous coli in the colon, cervical, and uterine. And these are somatic. In other words, the mutation was not transmitted by the sperm or the egg, it's in the cancer. It can be loss or gain of function. And there are numerous genes that, including SMAD4, that cause these. So it's not exclusive. One that has a strong association is cholangiocarcinoma, numerous genes. And here's Myhre syndrome down here at the bottom. So this is germline, gain of function, and has two main variants. I'm going to skim through this because I want you to go back and listen to Lois Starr's talk about genetics. Lois Starr's talk about genetics. So there are two main variants. We speak of them as isoleucine at position 500, which can change into valine, methionine, threonine, and leucine, or arginine at position 496, which changes to cysteine. So this is just a screenshot from a catalog of somatic mutations in cancer. Those of you who deal with cancer would be familiar with this. And to me, it was interesting because what it shows that SMAD4 in these cancers can both promote certain things, suppression of growth, promoting inflammation, invasion, metastases, angiogenesis, as well as suppress. So it has different types of activity. And this is this huge table only to show you how many different genes can cause endometrial cancer, which is what we'll be talking about later on. And here is SMAD4. So I'm going to show you a table from our paper in 2019. You know, as speakers, we try not to show complicated tables, but I'm going to try to walk you through this by using some highlighting. So first of all, there were three patients who were all female. They all had the arginine 496 cysteine variant, and they all had endometrial cancer. And so this was actually what prompted us to do the report. We thought this was pretty strong. For women who get endometrial cancer, they were relatively younger. By young, I don't mean less than 20, but these were not women who were older than 50. There's a lot of stuff on this table, so I'm just trying to draw your eye to those two things: the ages, the variants. The reasons for doing them, by the way, was for one woman, it was just a screen for a family history of cancer. For another one, it was part of the discovery of LAPS being part of Myhre syndrome. The one woman did already have endometrial cancer. And for those who are interested, the types of cancer are listed at the bottom. Some people have asked me what types, how aggressive was it? But I can tell you that people have been very pleased by even the that the woman who has the stage 4 is actually doing very well. So these are three other patients who had a different type of cancer. They were very young, okay? They had different types of brain cancers. So there was a vestibular schwannoma, very small, optic nerve sheath meningioma, very small, mesencephalic glioma. To say the word brain cancer, brain neoplasia is scary, but these were not aggressive or malignant tumors. So another part of this table focuses on the type of endometrial cancer, what the treatment was. And for this particular talk, I'm going to sort of zip by them. Um, were there other things going on? Very much so. So endometrial cancer is often associated with these risk factors: diabetes, precocious puberty, abnormal uterine bleeding, and some other features: macromastia, large breast, premature cystic ovarian syndrome, and obesity. So not everybody had everything. But, oh, excuse me, I'm sorry, the patient number 2 actually did have each of these risk factors, but these were things that we were looking for in addition to the gene. So what about the patients who had the brain cancer? One of them, a female, did have some of these risk factors. So we're trying to look not just at the gene, but other things. And I've highlighted here some of the serious problems. The third patient, the third woman who had the endometrial cancer, had a very severe restrictive pericarditis, had this feature of proliferation with abdominal adhesions. And the second person who had the brain tumor also had severe aortic stenosis. So in some ways, some of the bad things were sort of traveling together. Just to show you who some of these people are, These were the patients in in our paper 2019, and you might look at them to say, I'm not sure I can see the similarities. Some people might see some features, but they're not identical. This was a woman who had the brain cancer published by Lois Starr, and these were patients from Italy who had also a form of brain cancer. And a little bit about the brain tumors. This is from the literature. This was a patient who had a very small vestibular schwannoma. The patient who I showed you from Lois Starr, I do not have an MRI image of that patient. So I picked out an illustrative one. And what it is showing is that along the optic nerve, there's a thickening there. Uh, Next, for the patient in the literature who had the benign mesencephalic glioma, again, I don't have an illustrative image, but I do have, excuse me, I don't have the actual image. I don't think there was one, but I'm showing you something that's illustrative. And the mesencephalon is in the deep part of the brain. It's not on the top, it's not on the back, it's not on the front, it's deep down. So the hypothesis is that a germline SMAD4 gain of function mutation, which is what we see in Myhre syndrome, can cause neoplasia. So this is our hypothesis. This table is from our paper, and I want to cite the website that we used. It's called Reactome. And this is sort of similar. It echoes that earlier diagram that I may have shown you in which you have pathways working together, and there's SMAD4 down at the bottom. The activation can occur by signaling activin or by BMP, but in the end, they sort of meet down together here. This is SMAD4. And one of the things that was interesting is we found this article about uterine cancer, and it talked about the activin signaling and the BMP signaling. And I'm not going to go through it for this talk. The bottom line is that even though it showed that TGF and SMAD4 can suppress endometrial carcinomas and BMP SMAD4 can promote it, SMAD4 was not implicated. I may have said that too fast. The SMADs can be involved, but not SMAD4 in particular. So patients with SMAD4 juvenile polyposis have not had an increased risk of endometrial cancer. So this is another group of patients with SMAD4. So implications, despite small numbers, we do feel that the association of Myhre syndrome cancer is plausible. There's an earlier age of onset than what is generally seen. It's a predominance of endometrial cancer based on 3 out of 6, and we think there is molecular plausibility. Overrepresentation of the SMAD4 arginine 496 variant is puzzling. We don't know it's because just a coincidence. It's just a coincidence that we had a small number of people. Perhaps the next 3 patients will have a different variant. But I will tell you that I've not heard or read of any new cases reporting this. So currently we do follow girls and women with the SMAD4 arginine 496 variant. I speak to the parents and to their caregivers elsewhere to look for what might be the prodrome. It's probably the wrong word, but we're looking for things that might be predictors. Premature puberty, early menstruation, heavy, painful periods. And I'm sure there are people out there shaking their heads because they have experienced this. Macromastia, large breast, and abnormal uterine bleeding. So this is part of, we think, this phenotype. And our goal, if we're correct, would be to identify, to be on top, to see what we can do to prevent or treat this from becoming actually cancer. And we don't know, this is a question mark, whether premature menopause plays into this. So I'm going to go back to my paper and I'm going to focus on the brain tumor, switching gears a little bit. And so these were some of the, I told you about the ages, relatively young. At least one patient, the patient that Dr. Starr followed, had very severe aortic stenosis and this restrictive lung disease. The variants varied. There was one patient who had the arginine 496 variant, another who had valine, and another who had a very rare variant. It's isoleucine at position 15 and it goes to threonine. In my collection, this is the rarest variant. So the tumors I mentioned before, but I'll say them again. One is called a schwannoma, a meningioma, and a glioma, and they were all small and benign. So I'm going to tell you about 2 new patients, and I have to start by thanking the parents who allowed me to present these, and also my colleague Sophia Dushru, formerly from the UK, now in Norway, and Indy Banerjee, who's from the UK. So the first patient, it turns out, has already been described. This is a girl who was described in a 2015 report from Sophia and her colleagues. about severe constipation. So it's an important paper for that reason. And this patient had short stature, obesity, developmental delay, autism, PDA, aortic hypoplasia, hypertension, early puberty, moderate hearing loss, closed neural tube defect, pyloric web, severe constipation. And so that's fairly typical for Myhre syndrome. And by the way, the variant was the isoleucine 500 to valine, and that's the most common one. To talk about the hypothalamic hamartoma, it was an MRI in 2018 and another one in 2020 that showed this tumor. Apparently, there's been no increase in size, and this individual had what are called gelastic seizures. This is not related to Myhre syndrome. This is related to having a tumor in that location, which I'll show you. And gelastic seizures mean it's sort of a laughing seizure. There's also something called dacrystic seizures, which seem like they're crying. So the second patient is a new patient, is not in the literature. This gentleman died when he was 22. An autopsy was not done. So I do rely on the mother's self-reporting. This gentleman did have the same variant. All was short, but was taller by young adulthood, 5'7", had been on growth hormone. Overweight had come. The overweight was attributed to drug use, color blindness, hearing loss, learning disability. The mother does not feel he was on the spectrum, but he has been in an IEP and he did need some academic accommodations. And there's some other issues having to do with his behavior and mental health. I want to show you his picture, which I think is very vivid because the mother had explained to me how he changed over time. And I think from this vivacious, dynamic young child, here he is in front of a science project in the ocean, to a young adult who really suffered very badly in his final years. And so his tumor was diagnosed in 2017. He actually had what's called laser ablation. So they tried to reduce it and actually had a biopsy to prove this. There were some additional lesions in different parts of the brain, in the thalamus, not just the hypothalamus, and I think there may have been one other part. And so this gentleman had these gelastic seizures and the dacrystic seizures, which refer to laughing, severe headaches, loss of skills, really very difficult time. Um, so let me see. Apologies. Here we go. I want to just show you just a general diagram about the brain. For this particular presentation, I did not have the opportunity to dive deep into these medical records, and the diagrams I'm going to show you are just illustrative. So hypothalamic hamartoma is rare, not cancerous. It's a lesion in the brain or the hypothalamus or some of the other locations. Where's the hypothalamus? It's sort of in the heart, the center, the deep part of the brain. You know, I've mentioned that there's the front part of the brain, frontal, there's the back, there's the surface. This is sort of the midbrain, it's deep in. And it regulates a lot of important autonomic functions such as hunger, thirst, temperature, passion, hormone regulation. That explains some of these unusual types of seizures. And this is just sort of a screen grab from a site showing you where these little lesions can be. This is a type 1, relatively small. They can be larger. And if we're trying to classify these different tumors in Myhre syndrome or these brain tumors, there's this really comprehensive, I think it's a WHO classification. We have gliomas, meningiomas, schwannomas, hamartomas, and to um, to me at least, it speaks to me about what is not there. We have not seen aggressive malignant tumors, at least at present time. So there are other growths that have been observed in some patients, but they're not exactly neoplasia, but they're new bone. So I feel it was appropriate for this talk. There's a 12-year-old male that I cared for. He had detethering of his spinal cord. He had recurrent pericardial effusion. He had this interesting, this unusual ossifying tumor. It was like a little lesion. The maxilla is your upper part of your mouth, and it was biopsied. It was considered ossifying fibroma. It wasn't cancer, and this young man had the typical variant. Also know of an 18-year-old man who has a severe cardiac phenotype, aortic hypoplasia, stenosis, hypertension related to renal artery involvement. And he has the rare variant, the threonine. He had a lesion under his left scapula. It appeared many, many years ago. It was biopsied. It was called new bone. I use the expression exostosis, and it's this tiny little circle there in the scapula. And finally, I know of a 31-year-old male who has had very severe problems, had pericardial stripping from chronic pericarditis, large airway stenosis, has the common variant, and he has some unusual lesions that were seen on a CT scan. They're just tiny little lesions called exostoses, and those are the little arrows pointing to his iliac crest, and in the femur, something called an enostosis, so bone growth on the inside. So since we published our 2019 paper, no one wrote me an angry letter to the editor to disagree. Perhaps they felt that way, but I received no communication. Mostly people were very interested. And there are these two patients now who are unreported, and with permission, we will try to go ahead and have them reported somehow. I have understood how parents, patients are really confused about what it means to have SMAD4. I know some people thought that if they had Myhre syndrome, we should be thinking about juvenile polyposis, or if somebody has HHT, somebody wondered if they should be screened for Myhre syndrome. But I hope you can see what the differences are. And I hope this talk clarified some of the differences between somatic and germline mutation, also the difference between loss of function, gain of function, which is Myhre syndrome. And so to conclude, I would say neoplasia appears to be a valid part of Myhre syndrome, although extremely rare. Endometrial cancer in women who have the arginine variant is a reality. I've tried to be frank in talking to these people about how we will watch. And the question is, well, what should we be looking for? And we look for these features: the premature puberty, the heavy periods, immediately get an endocrinologist involved and a gynecologist. It's beyond the scope of this particular talk what can be done, but certainly there are some testing that can be done. There's certainly biopsying, there is certainly imaging, and certainly some medications that can be considered. But it's very customized, and I don't want to promote this for everybody as a blanket approach, but this is what is done. So these non-malignant brain tumors have been described, and one could ask, should everybody with Myhre syndrome get an MRI? And I must tell you, we're close to thinking about that. We don't think it's based on this association with the brain tumors, but we do know there are some features that can occur. We call them hyperintensities, and that's part of the brain talk, the neurology talk. And it'll be mentioned in some of the stuff that I'll be talking about. So the brain MRI is not currently standard surveillance, but we might do that. We might also do an MRA to look at the blood vessels because we know blood vessels can be involved. I encourage other patients to be reported by their providers. I seek the interest of gynecologists, oncologists, gynecologic oncologists. I've worked with several who are very interested and very helpful. So I realize this may have been a non-rigorous talk because that's the state of the art. The state of the art, or the state of the knowledge, is to identify cases, to postulate, and to really seek the next level of building the cases and working with other people. And to acknowledge, I want to thank the families and their networks who are making events like this and future research possible. I always thank the advisory board for being my colleagues in discussing these, in particular Sophia and Valerie and Lois from Norway, France, and Omaha, the Myhre Syndrome Clinic team, a basic scientist that I started working with in Manchester, Dr. Banerjee. In Minneapolis, I want to thank a genetic counselor who was very helpful in reviewing this, and the co-authors from my talk who did review this to see if they had anything new, and we have not missed anything nor heard from other people. And so I want to thank you, and I look forward to hearing from people in the future.